Welcome to the Interventional Glaucoma podcast, brought to you by Elios Vision. Join us for unscripted discussions about the latest innovations in interventional glaucoma with leading ophthalmologists in the field. On this episode of the Interventional Glaucoma podcast, host Professor Gus Gazzard is joined by Dr. Ahmad Elsahn to talk all things excimer lasers and their application in glaucoma today. Let's listen in.
Hello again, everyone, and welcome back to the next episode of Interventional Glaucoma, the podcast that's trying to bring you more information about surgical approaches to glaucoma and, more widely, a change in that mindset of drops, and always drops into something that's a little bit more interventional, where we can balance the risks and benefits of the various different approaches and interventions that we now have available to us. I'm very glad to be able to welcome today Dr. Ahmad Elsahn, who is a both dual-trained glaucoma and refractive laser corneal specialist. He has a PhD in corneal excimer laser expertise and is currently the head of the ophthalmology service at the Sherwood Forest Hospital's NHS Foundation Trust here in the UK. So he's got a strong clinical background in general ophthalmology, glaucoma, cornea, but also experience in that cutting-edge basic science and clinical research that is so valuable when we're discussing new developments such as excimer laser. So what we're talking about today is the use of excimer laser specifically in the glaucoma environment. And obviously we're going to want to hear a little bit about where it comes from, the differences between excimer and other forms of laser. What are the advantages of excimer lasers over other forms of laser for reshaping, changing, or ablating tissues? But I think I'd like to go right back to the beginning now and just ask Ahmed, can we start off with what is it that really differentiates an excimer laser from other kinds of optical lasers that we're more familiar with? We all know about argon, we all know about visible wavelength. We may even know about sort of invisible wavelength diode lasers in the context of ciliary body ablation, for example. But what is it that differentiates the excimer laser from these other forms of optical laser?
So basically, excimer laser is different. Excimer comes from excited and dimer, and the unique thing about excimer laser is that the dimer that is formed is not formed naturally when both molecules are resting. So it's formed between a noble gas, which is usually stable and it doesn't interact with other molecules, and the halogen, which is very reactive. In normal natural forms, they won't actually bind together. But what happens is we excite them with a high electric voltage, and when they're excited, they form the compound. So in refractive surgery, it's called argon fluoride, formed between argon and fluoride. And in excimer laser trabeculostomy, used in Elios, this is formed by xenon chloride. And they both have slightly different characteristics, slightly different wavelength. When this excitation happens, it's unstable. So it goes back to the natural stage and release a photon. This photon has very high energy, and when collimated together within the laser chamber, it forms this ultraviolet laser. So it's different because ultraviolet is very, very high energy, but also doesn't cause a thermal effect like other lasers. So, when we talk about lasers, we always have, things from science fiction, like, in Star Wars, when Jedi Knights use lightsabers to cut through thick gates of steel. And we see this thermal effect and how melting happens and stuff. This doesn't happen in excimer laser. Excimer laser is a cold laser, and there's no thermal effect to it.
Yeah, that's pretty much what my children think that I'm doing when I'm talking about lasers, and I think most of my life is spent in some shape or form with a lightsaber out there. Sadly not, but in terms of the excimer, it is almost for somebody who's very much a kind of knife and suture surgeon, if you like, traditionally. The excimer laser almost feels like magic. I mean, it actually, these very high photons, these UV photons, that don't heat tissue are able somehow to break apart bonds. And what do they then do? If they don't heat the tissue, do they evaporate the tissue? Are they breaking up the individual molecules into component parts? What happens then?
So what happens is that the energy is so high and so precise in a very small area that the energy level becomes so high that it disintegrates the intracellular bonds between the cells and the tissue. There's an increase in pressure rather than an increase in heat. And this produces what's called a plume, a tissue plume. So this tissue plume is basically plasma and cell components, and it escapes. So in refractive surgery, it escapes up into the surrounding area around the cornea, and it's actually aspirated by a specialized equipment into the laser machine. In Elios, it produces the bubbles that we see, and these go just through the aqueous. And also, it doesn't penetrate at all. So it's, in terms of the energy itself, it's so precise, it happens within about 0.3 microns. So it doesn't go anywhere else.
You talk about the bonds breaking within the cells. So these are actually molecular bonds breaking. So you're ending up with really microscopic gas and visible bubbles, but microscopic components within that. You're not ending up with any debris that's going to block up trabecular meshwork or anything, are you?
No, they're mostly gas and basically hydrocarbon compounds, very, very tiny stuff. It's not debris in the form of like cellular debris. It's very, very fine stuff.
Yeah, I think that's an important distinction to make, because certainly one of my misconceptions was that there was somehow going to be some sort of cellular debris being produced, because you've got very precisely controlled holes into the trabecular meshwork. But actually, what you're producing is vapor and compounds that will be very readily and rapidly and safely reabsorbed. I also understand that neither the probe nor the tissue heat up at all. Is that correct?
Yeah, that is correct. So, and you have to have the probe in very, very close proximity to the tissue in order for it to affect, because the penetration of energy is very, very minimal, very, very small. It's between 0.3 micron and 4 micron and more in longer wavelengths. So it dissipates. And that's a nice thing about it, because it doesn't cause effects to adjacent tissue. And that's why it's used in refractive surgery and trabeculostomy.
So what you're saying, Ahmed, is that the laser energy is very closely absorbed to the tip of the probe, and therefore, even if there were an accidental discharge into the anterior chamber, not that that would be possible or likely, but if there were, we don't need to worry about the depth of laser penetration being too great, presumably, because that's set by the physics of the laser. Am I getting that right?
That's correct, yes. So the penetration is very precise. If it discharges, in the middle of the anterior chamber, you just lose that shot, but it doesn't do anything. And that's why we don't use safety goggles with any Excimer laser in refractive surgery or in Elios. The other thing is that there was, when this first came about, when it was first invented in the 80s, there was worry about, UV light can cause, changes in cells, carcinogenic, mutagenic, etc. But it's not the case with Excimer laser, because it's the plasma protects the nucleus. So it's very, very safe because of its precision.
Yeah, I mean, it's interesting you mentioned safety there, because I wanted to move on to thinking about sort of safety and efficacy of Excimer lasers specifically in glaucoma. Even glaucoma guys like me, who previous to being able to carry out Excimer trabeculostomies in the last 6 months or so, prior to that, I'd never handled an Excimer laser. I've not done any photorefractive keratectomies, PRKs, LASIK, or anything like that. I stay clear of that. But what I'm excited about looking at the literature is that there does seem to be quite a lot of safety literature going back quite a long way for the Excimer trabeculostomy procedure.
Yes, that's right. So it was developed in the 70s. Initially, there were 3 IBM engineers that were looking at if Excimer laser, because of its precise applications and how it can affect different elements like metals and other things, if this can be used biologically. And they looked at different things, and initially they thought of, yes, maybe we can use it in refractive surgery on the cornea. So in refractive surgery, you can shape it as a lens, a very complex lens, even addressing higher order aberrations, let's say, very, very minute changes in shape. And that's why, we've seen scanning electron microscopy images and other microscopy images with Elios that shows it's so precise. The opening it produces, it's a circular opening and has very sharp edges, which you rarely produce in biological samples.
Yes, I think that the precision of this as a device is really quite staggering compared to the crudity of what we're normally doing with a scalpel, or even more so if we were just talking about passing a suture through Schlemm's canal and just ripping out trabecular meshwork, which is even more destructive and traumatic to the associated tissues. What's really interesting about that is how that affects the tissue remodeling and healing afterwards, and the scarring and what happens over time.
Yes, because it's so precise and it doesn't actually cut the tissue, there's no release of cytokines and there's no inflammation. Basically, the cells are removed from where they are. They lose the bonds and they just kind of float away. So there's no inciting of inflammatory mediators.
I think that's probably one of the most exciting aspects, is not just the precision at the time of surgery, but precision over longer period of time, that you're not creating a nice round hole that then scars up and is remodeled by fibroblast. You're creating a nice round hole which doesn't generate that sort of healing cytokine induced scar formation, and that's really interesting. What's also fascinating about that, of course, is the effects will be less dependent on the individual patient's biology, and that's another way in which it differs. Of course, one of my loves is SLT, but that's another way in which this differs from SLT, because selective laser trabeculoplasty entirely relies upon cytokine release, entirely relies upon some form of healing process, some form of cell division, whereas what we're doing here is a really very different thing indeed. It's a precise surgical excision without trauma, which I think is really interesting. I'd like to just come back to thinking something a little bit about the safety aspects, because we do have some safety data out there for quite a while, but there is data there from 1996 when the first trabeculostomies were carried out with an excimer laser, and then also sort of more data over the following years. Would you like to talk about any of that at all? Or?
Yeah, so the first excimer laser trabeculostomy study was conducted in human eyes was in 1996. And the preliminary results found that the IPE was reduced by 11 millimeters of mercury over the follow-up time of 5 months. It was only done on 6 patients, for about 6 patients. And then there's another study in 1997, 22 out of 27 eyes, pressure was reduced. And it stayed like that. Various small studies happening here and there showing some reduction in intraocular pressure, around maybe 20 to 25% reduction in intraocular pressure. And I think we have more data now. So we have data for, I think Elios has data for 8 years now, showing very good results as well. If there is, the main problem is trabecular dysfunction, then this does allow aqueous to bypass the trabecular meshwork. And then it's up the pathway that I think would determine the amount of pressure. But we've had very good results over the years.
Yes, I mean, I think in total now, if you combine some of the Teutoburg-Harms papers and look at some of the very early data and then the later longer-term follow-up, we've now got experience in research environments carefully followed up for quite a long period of time of several hundred, many hundreds of patients, really speaking to the safety of the procedure as well as the longevity of the pressure lowering effect of the procedure. And I think that's one of the things that I am excited by. We've got our hands on this device now in a sort of commercial rather than a research environment. We can now actually offer this to our patients, but in fact there is quite a wealth of long-term follow-up data and basic underpinning clinical research behind this in terms of both safety and effectiveness. A couple of words to wrap up. I think we should just remind ourselves that there's a real minimization of any form of cytokine-induced wound healing response because of the lack of a traumatic effect on surrounding tissues. We've got a very highly localized effect with great precision we know where we're placing this probe, and we know that it's not going to treat with the laser anywhere else. It's got a very short penetration, so we're only going to be ablating tissue that we're in contact with. And of course, we're achieving these pressure layering effects without leaving anything behind. So, in the words of other contexts, nothing left behind, no man left behind. Thanks very much, Ahmed. Anything else that you want to finish off with in the last few seconds?
It's one of those things where we say that people always associate laser to heat. And it's very important to know that Excimer laser is a cold laser. It doesn't produce any heat.
So a cold, precise, surgical, cutting laser, making little cookie cutter holes into that trabecular meshwork through to Schlemm's canal, so the aqueous can bypass that primary blockage in the juxtacanalicular trabecular meshwork, where so much of the restriction to outflow occurs, and in doing so give us a long-lasting opening and bypass of TM to lower the pressure for a decent period of time. So thanks very much, Ahmed. I think we'll wrap it up there, and I look forward to the next episode of the Interventional Glaucoma podcast. Thank you.
Thank you, Gus.
Thank you for tuning into this episode of Interventional Glaucoma. Want to hear more? Be sure to click the subscribe button to be notified of new episodes. For more information about this episode's topic, read the show notes at eliosvision.com/OUS/podcast. Elios Vision GmbH is the EU distributor of Elios, manufactured by MLAs GmbH, and the Fido laser applicator, manufactured by Vinert Fibre Optics GmbH. Elios is CE marked and licensed for use in the EU and is currently under investigational use in the US. Please refer to the full disclaimer in the show notes.